Good morning. Welcome to today's Clyvera webinar with co-founder Dr. Rohit Sud. My name is Jane Wallen, and I help run marketing and communications for Clyvera. Dr. Sud is not only a co-founder of Clyvera, but a board-certified oncologist based in Arizona. Thank you for joining us today, Rohit.
Thank you. Thank you, Jane.
Yeah,
It's great to be here with you and pleasure to do this with you always.
yeah.
These kind of conversations are exactly why we have built Clyvera, and I'm so really glad that we are taking the time to actually be here and talk about this important topic.
Yes, I love these. I love these Q&As with you. They're incredibly helpful. So thank you so much. Today we will be discussing, as we were planning for our next webinar, it was a month ago in March, and it was Colorectal Cancer Awareness Month, and so it's kind of on the brain, and it's a cancer that affects a lot of people. So Rohit wanted to do that topic, so we will be discussing colorectal cancer today. Are you ready to dive in with some questions I have for you?
Yes, absolutely.
All
And this is
right.
a topic that I feel strongly about, both as a clinician who cares for patients with colon cancer and help patients navigate these diseases. So let's dig in.
Okay. All right. So we'll start kind of general. Um, Colorectal cancer is one of the most preventable cancers, yet it remains a leading cause of cancer death. Why do you think awareness is still such a challenge?
Yeah, so that tension, that conflict, highly preventable, yet still deadly, is honestly what troubles me most about
Mm-hmm.
this cancer. I think there are a few things at play. First, of course, there is this stigma factor. Nobody wants to talk about their butt. Colorectal cancer involves parts of the body that people don't love talking about publicly. It's not good cocktail conversation. That breast cancer or heart disease might be more palatable.
Mm-hmm.
Not that any of that is less deadly, but so colorectal cancer does not become part of that conversation.
Mm-hmm.
Secondly, the symptoms of early stage colon cancer are usually absent and easily to rationalize away. That okay, I'm having a little bit of constipation here, some diarrhea for a few days. It's a mild discomfort in the belly, but so people tend to brush those aside much more easily, chalking it up to stress or dietary changes or what have you.
Mm-hmm.
And the most important thing I feel is that the screening requires a level of healthcare engagement, like involving in talking to your doctor and your doctor referring you to that kind of a screening, which I think in our busy lives, most Americans simply don't have either time or access to, and
Mm-hmm.
and they and that does not get prioritized until something really feels wrong. I'm feeling well, so why do I go and do it? With breast cancer, if you feel a lump, you'll go, but
Mm-hmm.
with colon cancer, you essentially wouldn't feel anything. So
Mm-hmm.
why would I go? So that's what actually makes this a preventable but a
Mm-hmm.
deadly cancer and important to talk about.
So you mentioned a couple, but what are the most common early warning signs that people should not dismiss?
So any change in your alteration of your bowel movements, anything like blood in your stools that you may notice, abdominal pain that does not go away,
Mm.
weight loss that is not planned or something that happens unnaturally, those would be things that you would definitely want to discuss or bring to your doctor's attention, and that may lead to additional evaluations down the road.
Okay. And I could see what you're saying about, yeah, I could see someone just saying, "Oh, you know, our our mind body manifests so much in our guts." So I
Right,
can see why
exactly.
people wouldn't necessarily be alarmed, right?
Exactly. And till
Yeah.
it's too late, unfortunately.
Yeah, yeah. Do you have any stats on the scope of colorectal cancer or how many people it affects a year?
Yeah, the numbers actually are sobering. Colorectal cancer is the third most commonly diagnosed cancer in both men and women.
Mm,
We're looking at almost 150,000 new cases each year and around about 55,000 deaths annually.
mm.
So globally, it's one of the top three cancers by incidence and mortality.
Wow.
What is particularly alarming is that now we're seeing even younger and younger adults,
Mm,
people in their 30s and 40s, getting rectal cancers and other
mm-hmm,
and colon cancer. It's historically not been the case, but now there is a realization that younger people are getting these cancers. We just don't exactly know why, but the
mm,
trend has alarmed and has actually caused a major guidelines organizations to actually rethink their screening recommendations.
mm-hmm.
And I'm sure we'll get into that later.
Yeah,
Yeah,
yeah, we'll
later.
definitely, yeah, we have to make sure we do because I have a lot of questions coming out of that comment. Um, well, actually, let's just move into it. The next question is who should be getting screened and at what age? And I guess the other question is, right, why would someone younger get screened? So let's do sort of what the recommendations are right now and then looking at the fact that it's moving younger. What does that mean?
Absolutely. So, yeah, the screening guidance has changed as we just discussed. And it's an important update for average risk adults. The USPTF, the U.S. Preventative Services Task Force, now recommends starting screening at age 45, and
Mm-hmm.
that has been taken up by American Cancer Society as well. That is lowered from previous age of 50, specifically because of the rise of early onset colorectal cancer. So if you have a
Mm-hmm.
family history of colon cancer, uh, um, uh, uh, or certain kind of like polyp based diseases, then you should start screening earlier,
Mm-hmm.
often at 40 or even younger. We are seeing that African Americans are at a higher risk of colon cancer and may benefit from earlier and even more frequent screening.
Mm-hmm.
So the key message here is not to wait for symptoms. By the time you have or you feel something, the disease may be more advanced. So it's extremely important for patients to adhere to those guidelines that
Mm-hmm.
at least start talking to your doctor that 45 is the age. um,
That
uh, you
everyone
know
should.
everyone should get
Mm-hmm. So
screened.
if you're one of the people you just mentioned who could be a higher risk,
Hmm.
and you go talk to your doctor, is it something that generally they'll work with you on? Will insurance help you out? Like, do do people who feel that they're high risk get get reception in the medical field to help them get those tests? Or how
Absolutely.
do you go about navigating that? I guess.
So the guidelines actually are rather fluid in actually
Okay.
figuring out whether or not you so the guideline of 45 years of age is that's what it is. It's a
Mm-hmm.
guidelines.
Mm-hmm.
And when you go to a doctor with symptoms, the doctor has multiple things that they can do. There's some stool-based testing that they can order.
Mm-hmm.
There is a stool fecal a fecal test for called a FIT test, the fecal immunohistochemical test, in which you can do at home annually, or a stool-based
Mm.
DNA test that is now available called Cologuard that your doctor could actually recommend that you do. These are done every 1 to 3 years. So when you come to your doctor with symptoms, probably these may not be the first things that your doctor actually orders, but
Mm-hmm.
then eventually, as a screening recommendation, these do find value in certain different risk subgroups. And age groups.
Okay.
The second is a structural examination, like a colonoscopy, which is the gold
Yeah.
standard even today.
Yeah.
It's recommended that it's done every 10 years, and if normal, because both it detects and removes precancerous polyps, which
Right.
is preventative in
Right.
its own. Um, uh, many patients do not like the prep and
Yeah. It's
whole
not that fun.
the whole idea the whole idea of I know my wife is a gastroenterologist, and I keep telling her that you guys need to get better with this prep. recommendation, but yes.
Yeah. Well, what else are
But
we gonna do, right? I don't know.
I know, and but you have to empty the colon to get a good view, and
Hmm.
there is a non-invasive sort of, like, you're not doing a colonoscopy, uh, called a CT colonography is another option.
Mm.
And the right choice actually depends on the patient's risk level, their preferences,
Hmm.
and whether they are able and willing to undergo sedation for colonoscopy and stuff like that. So
Hmm.
there are multiple nuances that you can then subsequently discuss with your doctor,
Yeah,
and have a more nuanced discussion. So, a test done imperfectly is better than a perfect test
nothing.
never done.
Yeah.
So I think
Hmm.
I tell my
Hmm.
patients that, oh, fine, if you don't want to do colonoscopy, at least get a Cologuard done, at least get a fit
Mm.
test done.
Hmm.
So some kind of screening is important. So the best screening test actually is the one that you'll actually do, whether
Yeah.
it's colonoscopy or a Cologuard or a fit test. We can say that the best test is colonoscopy, but
Hmm.
that is that may be set aside because of personal preferences.
Hmm. Okay. So I guess let's just quickly list. We've already talked about them all, but can you just list like what each screening is in order of
Right.
what people should do? I guess.
So, as I said, there is no one preference of doing
Yeah.
a particular. If you ask the medical community, they will say colonoscopy, being the
Yeah.
gold standard, would be what
Yeah.
would be recommended.
Yeah.
But there is a FIT test, which is the fecal
Which.
immunohistochemical
Yeah.
test, in which can detect certain cancer cells in the stool.
Hmm.
There is a stool DNA test, in which
Hmm.
has a little bit more higher sensitivity
Hmm.
in detecting cancer DNA. That's called Cologuard. It's recommended
Hmm.
to be done every
Oh,
one to
okay.
3 years. One to
Okay.
3 years. Then there is colonoscopy, of course, and
Hmm.
a CT colonography, which is a CT imaging of the colon, but requires the same kind of prep that you would undergo with colonoscopy.
Oh,
Colonoscopy is the
okay.
only one that will detect the polyps, be able to biopsy them, remove them, and prevent, if that polyp was cancerous
Growth.
or
Okay.
precancerous, further
Okay.
cancer progression. So,
Okay.
yeah.
So why would someone do the CT instead of a colonoscopy?
I think if patients, say, have issues with undergoing sedation,
Mm.
to undergo the colonoscopy process requires you to go under some kind of anesthesia. So if they
Okay.
have those issues, if they are unable to fit that into their schedule,
Yeah.
or it's a good alternative option, but
Hmm.
not the
Okay.
preferred option.
Okay. Okay. So let's move on to lifestyle factors. Are there specific things like diet or exercise that people should be paying closer attention to in terms of colorectal cancer risk?
Yeah, absolutely. And the evidence here is really strong.
Mm-hmm.
A diet is a rather big one. High
Mm-hmm.
consumption of red and processed meats is consistently linked to increased colorectal cancer
Mm.
risk in various studies. A diet rich in fiber and whole grains, fruits, vegetables appears to be protective.
Mm.
So, physical inactivity is also an independent risk factor. Like,
Mm.
regular moderate exercise has been shown to reduce the risk meaningfully.
Wow.
Obesity, particularly abdominal obesity, is also associated with a higher risk, and as is like heavy alcohol and use and smoking.
Mm-hmm.
Um, there is some data about type 2 diabetes appearing to increase the risk as well.
Mm.
That's not well established.
Okay.
But just moving more, eating more plants rather than meats,
Mm-hmm.
limiting processed meat and alcohol, those changes really matter. So
Yeah.
those are lifestyle changes that I always talk to my patients about, who have had colon cancer or who
Mm-hmm.
are coming in for other alternative,
Okay.
evaluations.
Yeah. Okay. That was a good overview, although detailed. Maybe we didn't go so overview, but that's all right. Okay. So let's talk about diagnosis and treatment. Once someone receives a colorectal cancer diagnosis, what does typical treatment journey look like?
Uh, um, it
Is there a
varies,
typical?
Jane.
Yeah, maybe typical is the bad word, right?
It varies for patient, for stage.
Mm-hmm.
But let me give you a general arc of how we look at this. So after diagnosis, usually confirmed after colonoscopy and a biopsy, you
Mm-hmm.
get to staging. That's the first question that most patients ask me when they walk into my office. What's the stage?
Yeah.
Of my cancer? And that involves an approach to get CAT scans and sometimes MRIs if it involves the rectum or the liver, PET scans to see how far the cancer has spread.
Mm-hmm.
You know, so it could be localized or it could be more advanced. So for localized diseases, you would surgery would be typically the primary treatment, following which, in certain cases, there might be role for additional systemic therapies, but surgery would be primary for localized cancers.
Mm-hmm.
For rectal cancer in particular, there is a difference because we do tend to use radiation in conjunction with chemotherapy,
Mm-hmm.
and these are often given before surgery to shrink the tumor and give the best
Okay.
chance for the patient to actually have a good outcome. For more advanced disease, with systemic therapies like chemotherapy, target therapy, in certain cases, immunotherapy, depending upon the patient's tumor molecular profile, has become the standard. And so most patients, especially younger, I would refer them to a genetic counselor, because if there is a concern for hereditary risk, that should be addressed. So
Mm-hmm.
the journey can span months to years,
Mm-hmm.
of treatment before their cancer uh, can be said to be in remission,
Mm-hmm.
and that has to be and so there's a coordinated effort involving support staff, nurses, social workers at times, and genetic counselors, um, uh, to make a real difference in the outcomes and the quality of life. We
Mm-hmm.
do also have to factor in the pain that sometimes some patients actually go through with treatment and the disease itself.
Mm-hmm.
So,
Um, what is, I know it's so stage dependent, but what's the prognosis in general if you catch it early versus later?
so early early disease outcomes are definitely you know uh, um, better. As we
Mm-hmm.
said, with colonoscopies, you can actually detect them early,
Mm-hmm.
and you can resect them,
Yeah.
the polyps, and hence cause alter the nature of the disease itself.
Mm-hmm.
Stage matters enormously in prognosis. So
Mm-hmm.
stage 1 colon cancer, the 5-year survivals could be up to 90%.
Mm-hmm.
For stage 2, you know it is around 80%. Stage 3 with lymph node involvements, it roughly drops to about 50%, 50 to
Mm-hmm.
70%. and
Mm-hmm.
and of course stage 4 with cancer that is spread to distant organs,
Mm-hmm.
the 5-year survival rate is around 15%.
Oh wow.
So these numbers are stark. Catching the
Mm-hmm.
disease early is not only a marginal advantage, it's a meaningful
It's
advantage
meaning. Yeah.
between cure in earlier stages, even stage 3,
Right.
and a terminal diagnosis.
Yeah.
We are seeing an impact from our treatments, and patients are living longer, but in stage 4 cancer, still the cure seems elusive.
Okay.
Um, as I said, if you can identify cancers in stage 1, 2, and 3 through screening, and people may not have any symptoms, you would impact the arc of their cancer journey much differently.
Yeah. So you, so there is potential for cure in those earlier stages.
Yeah, there
Yeah.
is.
Okay. That's amazing. How has the treatment evolved over the last decade, and are there any breakthroughs that patients should know about?
Yep. So this is generally exciting.
Hmm.
Molecular profiling of cancer has become pretty routine in any cancer that we see these days.
Hmm.
We have tests for specific mutations, and so we can identify there are certain mutations that are unique to colon cancer, for KRAS, NRAS, BRAF. there is a mismatch repair status that we can actually identify through those molecular profiling studies. And that can guide us about target therapies that are likely to work in these patients.
Mm.
Like immunotherapy has been a breakthrough in a specific subset of patients, especially a subset that we call MSI high tumors. They can have remarkable responses to immune modulation with checkpoint inhibitors,
Mm-hmm.
and sometimes actually achieving complete responses. I've had patients with more advanced disease that have even avoided surgeries in certain situations.
Mm-hmm.
So it is there has been real progress. And
Mm-hmm.
of course, surgical progresses we have not talked about, but the surgical techniques have changed, and we are looking at minimally invasive surgery in many situations, like robotic assisted as well. um, and uh, and so another thing that actually has come lately is liquid biopsies and identification of circulating tumor DNA,
Hmm.
which allows us to detect for recurrences early, event prevent, like monitor therapy in real time, and treatment responses in real time, and also basically avoid another biopsy, because we can get that same tissue and DNA from the blood and test it for molecular mutations at times.
Hmm. Wow.
So a lot of things have been happening
Mm-hmm.
that I'm super excited about in this field.
Mm-hmm.
A lot more has to be done, but
Mm-hmm.
a lot is happening.
That's amazing. Good to hear. Okay, let's see. As a clinician, what gaps do you see in how patients are managing their health between appointments? And has that been a motivation for working with Clyvera? Because I always like hearing why you're working on Clyvera and how do you see something like that helping? But what are the gaps? What are patients missing in between their appointments?
Yeah, thank you, Jane. Yeah, this is something that I have felt acutely, throughout my clinical career in the last,
Mm-hmm.
15 years as an oncologist. That really the patient's cancer journey doesn't pause between appointments,
Mm-hmm.
but our ability to support them often does.
Mm-hmm.
Patients go home after a chemo infusion or an appointment, and they're managing side effects, you know, judging and taking multiple medications, trying to remember what their doctor said. And many a times it's like that knowledge gap that patients have uh, takes them into you know darker corners at times
Mm-hmm.
of the World Wide Web. They keep worrying about symptoms. They don't know whether to flag or not, whether they should call their doctor. I'm just having the symptoms. Like, they don't realize they don't want to bother the doctor's office as well.
Mm-hmm.
So by
Mm-hmm.
the time we see them at the next visit, uh, important details of all this has been lost.
Mm-hmm.
They've waited too long to raise the concern. Either it's gotten worse or they've forgotten, and these things tend to happen again, and
Mm-hmm.
so they suffer through it. So that is something that I feel that that in between appointment, in between healthcare contact, information that gets missed and lost. And
Mm-hmm.
beyond that, there's these clinical gaps. There is a knowledge gap.
Mm-hmm.
I was just talking about that. I just find as troubling. Healthcare is generally hard to navigate.
Mm-hmm.
Patients are handed a diagnosis and
Mm-hmm.
suddenly expect to understand staging,
Yeah.
treatment options, insurance authorizations,
Yeah.
specialist referrals. It's a maze that
Mm-hmm.
even an educated person who's undergoing the stress of actually a diagnosis as grave as colon cancer,
Right.
can find daunting
Yeah.
to navigate. Even resourceful find it overwhelming.
Mm-hmm.
When you layer fear and the fatigue that the treatment is doing on top of that, it becomes fairly paralyzing.
Mm-hmm.
So that was exactly why Clyvera was built to solve this conundrum with our patients and
Yeah.
everything. We wanted to create a true uh, AI based healthcare companion, that stays with the patient throughout their entire journey,
Mhm.
not just during the 20 minutes or 30 minutes that they are in my office.
Mhm.
With Clyvera, patients can now track their symptoms, side effects, daily, and nothing stops, hopefully nothing slips through the cracks between these
Mhm.
visits then.
Mhm.
Medication reminders might help them try to stay on top of complex regimens,
Mhm.
including nausea regimens that we tend to have. So they can chat with the with the with an artificial with Clyvera, and
Mhm.
gives them a place to ask questions
Mhm.
at any hour, and health concerns that don't have to wait for office hours,
Right.
and get a clear, reliable guidance that is curated to them,
Right.
highlighting rather than going down the internet and the Google rabbit hole,
Right. Right.
or even ChatGPT rabbit hole in the middle of the
Right.
night.
Right.
You know,
Well, and I mean, the big things for me are the privacy,
yeah,
is that it's private, but also the reliability, right? And
absolutely.
and
So
and it knowing your history, because it's got your whole history in the app, so it knows your history, and
so
it's
so
pulling from reliable sources. Like,
yeah,
it's so easy to get spun out on normal
absolutely,
AI or the Google or
absolutely.
whatever.
So
Yeah.
so
I
so
can't
we
believe I just said the Google, by the way. Sorry. I'm
so
going to take
we
that back. But yeah, it's so easy to spin out using all those
It
tools.
does. Yeah, the World Wide Web is a dark place, and
Mhm.
we also built Clyvera to be a care navigation tool, so that patients that make because so much of what makes a cancer diagnosis is overwhelming than and not the medicine itself. It's a system, knowing what questions to ask,
Mhm.
understanding what the next steps are,
Mhm.
preparing for your upcoming appointment so that you don't walk out realizing that you forgot to mention this to your doctor.
Yeah.
Clyra hopefully will be the tool that helps you with that, and
Mhm.
underpinning everything is education. So we want our
Mhm.
patients to be well educated about their diagnosis,
Mhm.
informed about things that are specific to them with their other medical concerns and questions and medical diagnoses that they do carry. So it's not only just another AI app, but
Mhm.
it is a companion, and
Mhm.
that's what we are hoping. And you mentioned about privacy,
Mhm.
and I can segue into that and say that it's a question that every patient should be asking of any healthcare app that
Mhm.
they use, and honestly, most people don't.
Yeah.
Is about privacy, and HIPAA
Mhm. Mhm.
exists to protect privacy and security
Mhm.
of your healthcare information. And the
Yeah.
stakes are particularly high in oncology. Your
Yeah.
diagnosis, your treatment history, your symptoms, your medications are among the most sensitive personal data that you have.
Yeah.
And many consumer wellness apps are not actually covered under HIPAA.
Mhm. Oh no, we lost Rohit. Everybody. I wish I had some funny jokes to say, but I don't. Something entertaining to keep you here. One moment. Hopefully, we can get him back. We have a couple more questions. In the meantime, since we were talking about the app, uh, we are about to launch beta. So if you haven't signed up to be notified, please go to clyvera.ai and there will be a sign up, and then you'll get notification once we launch our beta, and you can help us develop the app. So,
All right.
all
I'm
right,
back.
let's get back to it. Yay. I took it as
Sure.
an opportunity for a shameless plug. So we'll get people to help us build this app and test it out. So, I was going to say too, I think what I'm gathering from what you're saying is don't be afraid to call your doctor too, right? I
Yes.
feel like that is a theme you might keep hearing kind of like in everything you're saying is don't be afraid to call your doctor.
Yes. Um, I'm hearing an echo.
Are
Are you
you?
hearing an
Okay.
echo too?
Oh, yeah, there is an echo. Best laid tech plans, right? Are you there still?
Yeah, I'm here.
Okay, that
Okay.
sounds better.
Yeah. Okay. So, as I was talking about HIPAA in general, and yes, privacy is important,
Hmm.
and patients should always ask, if this app or any website that they're putting their information onto,
Right.
uh, does it have, or is it held to HIPAA standards?
Yeah.
Is my
Yeah.
data encrypted?
Yeah.
Who can access it,
Yeah.
and under what circumstances?
Hmm.
And so HIPAA compliance, uh, foundational design decision, something that we, you know, added to the end of our app development process, but we started it from the start.
Right. Right.
And that is something that feature that we built, whether it's symptom tracking, medication reminders, AI chat, or an appointment prep, was architected with privacy.
Yep.
Uh,
It's yes, I think that's a really important differentiator, right? Is that it's not after the fact, it's built into the design.
yeah,
And there's a reason HIPAA exists. There's a reason our medical information is considered worthy of being kept private, right? So
right.
we don't want to sacrifice that just for the convenience of using an AI chatbot. So
Yes.
it's really, 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 really important. Really important.
And that's very important when we go for the process of developing this.
Yep. Okay. Let's see. Back specifically to colorectal cancer, as we wrap up and before we get to some submitted questions, what is the one thing you wish everyone knew about colorectal cancer that they probably don't know?
Um, it's doesn't have to be a death sentence, and for most people, it doesn't have to happen at all.
Mm,
It is uniquely preventable cancer
mm,
because colonoscopy can pick up precancerous lesions,
mm-hmm,
some precancerous polyps, even before they become invasive cancers.
mm-hmm.
It's an extraordinary opportunity that we have that we do not have with other
With other
malignancies.
cancers, yeah, yeah,
Yeah, so a colonoscopy can not only detect early cancer, prevent cancers, even cure by just resection
right,
of certain polyps. So I think it is something that everyone should who's everyone who's watching this should have it as a takeaway,
yeah,
that it is important to get screened and talk to your doctor if you're 45 years and older
mm-hmm,
or younger with a family history.
yeah,
Make appointment. It'll be the highest value thing that you do for yourself and your family, the long-term health.
yeah,
So don't wait for symptoms.
yeah. Okay, that's good to know. Okay, I'm gonna go to the chat and see what kind of questions we have. Okay, one is Given that there's 10 years between colonoscopies, does that mean it takes a long time for new polyps to develop into cancer? Does that feel too long? Or should we be asking for those tests sooner?
So typically, the polyp is the stage of development for polyp to a cancer. Um, Let me rephrase. The stage of polyp development from a cancerous clone to be formed in the colon is
Mm-hmm.
about 8 to 10 years.
Mm.
So by the time you have polyp, you have had that clone grow up to that
Okay.
level. So that's why if your doctor finds that you have multiple polyps,
Mm-hmm.
they might have you come back and do a colonoscopy in 5 years,
Mm-hmm.
in 3 years. So depending on what risk polyps that they have, that you have, how many polyps have you had?
Mm-hmm.
Because there's always a risk that colonoscopies could miss polyps.
Mm-hmm.
So that's why those recommendations are built in. But for for a person who has complete colon, clean colon, there is no polyps that is noted. The likelihood of the clone of cancer starting and becoming a polyp is about 10 years.
Okay. Interesting. Okay, good to know. Um, are there any common myths that you find yourself having to debunk with patients on a regular basis?
Um, so the biggest myth is I'm not having any symptoms.
Mm,
Why do I have to get a colonoscopy? Uh, it is in the prevention setting, that is the biggest hurdle that we have to cross.
mm-hmm.
But otherwise, I think once it's diagnosed, the myths that we actually deal with is treatment related.
Mm,
Uh, Patients being skeptical about about modern science, about chemotherapy, and those discussions are nuanced and based on every patient's different concerns.
okay.
But the myths
Um,
to,
no, go ahead.
myths predominantly relate uh, to screening and delaying that process of getting a screening test.
Okay. Okay, let's see what else. Um, oh, here's a good one. My mother was recently diagnosed with colorectal cancer. What should I be doing right now to protect my own health given family history? And we don't have ages or anything on the question, but if you have a close family member diagnosed, what does that usually mean for you?
Very good question. Uh, that means that there could be, depending upon the age of your mother or your family member that was diagnosed, that you could have a genetic correlation to it.
Mm-hmm.
So we do recommend that patients who have been diagnosed less than 50 years of age for sure undergo a genetic counseling evaluation and get to see if they harbor a gene, and hence their family members can be tested for that gene
Mm-hmm.
and set up on an enhanced screening profile.
Mm-hmm.
The For all comers, we do recommend that if you've had a diagnosis of colon cancer in a family member, you should at least have had a colonoscopy 10 years before their age of diagnosis. So
Oh,
like
right, because that's
those,
how long it takes the cancer to grow,
yeah.
basically. Okay. Very okay.
So
Great.
if your mother has been diagnosed at 55, then you
Yeah.
should have a colonoscopy at 65.
Yeah.
No, I'm sorry, by 45. If she was diagnosed at 80, then you should have already had a colonoscopy
Yeah.
anyway.
So you would have already had it. Yeah. Yeah. Okay. Um, okay, let me look. Let's see. What is a typical day for someone going through treatment? And how can those of us who are caregivers or family members best support them?
That's a very good question. Again, it varies from the stage of the cancer, the treatment protocol that your doctor will design. That could include chemotherapy, that could include maybe uh, some oral pills that might require you as a caregiver to keep a log of how their symptoms are
Mm-hmm.
with regard if the patient himself cannot keep such a log,
Mm-hmm.
bring it to the doctor's attention if side effects actually develop, because many times patients will be too tired or brush the symptoms aside, uh, uh, and uh, and keep a compliance of those medications, because those medication regimens can be rather complex. So trying to figure out as to when do I need to take this medication, how many pills do I need to take for this, uh, or that. So it's important to keep as a physician. I always worry about, especially when most of our medications are moving oral. Uh, how is the patient actually going to navigate?
Yeah. Right.
In my 20 minutes appointment, have I explained to the patient completely?
Mm-hmm.
So it is the caregiver, the second years that the patients bring to the office, then take as much and much more importance. And hopefully, uh, with the help of the app like Clyvera,
Mm-hmm.
it might actually make it easier for them to actually
Yeah.
navigate that.
Yeah. Okay. Is surgery typical for most diagnoses?
Yes and no. So in stage one, stage two, and most stage three cancers, a priori surgery would be what the doctors would recommend. For stage four cancers, most cancers that are spread to other organs, surgery upfront is not something that your doctor will recommend,
Mm-hmm.
but possibly might find its role in certain limited advanced cancers sites, such as if there is a one or two spots in the liver or in the one or two spots in the lung. This can be fashioned in post chemotherapy
Mm-hmm.
if there is good response, and still impact long-term remission and cure from that aspect. So yes, surgery does form an important role in the initial cancer stages, stage one, stage two, stage three,
Mm-hmm.
and possibly also stage four in certain patients.
Okay. So, just my own question, and I think I know the answer, but I want to clarify. So, stage four generally means, and maybe for all cancers, that it's spread beyond the initial cancer site.
Exactly.
Okay. 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 Um, I've been putting off getting screened because honestly, I'm a little embarrassed. What would you say to someone like me to help them take that first step?
Um, it is going to be done in the privacy of you and your doctor's conversations,
Mm-hmm.
and find a doctor that you feel comfortable with to discuss this important aspect.
Mm-hmm.
And there are, gastroenterologists of various ilk,
Mm-hmm.
and if you feel more comfortable seeing a women gastroenterologist, or if you're more comfortable with a certain setting, then go visit those
Mm-hmm.
doctors and
Yeah.
try to identify. But the first step is actually to get out and see them.
Yeah.
But that's for colonoscopy. But there are other tests that we talked about. At least
Mm-hmm.
the Cologuard, the FIT test, the
Mm-hmm.
and the CT colonography. Those are all options that if you are not ready yet for colonoscopy.
Well, and this is something that I say and think all the time is everyone that's working with you in that doctor's office doesn't care. They see
Right.
it all the time. It's not embarrassing because they're used to it, right? Nurses see everything all the time. And so
Yeah.
it's not like you're going into a room where it will be embarrassing either.
Yeah, it's just that as a society we have been a little bit shy of talking about our uh, evolutions and
Yeah.
biology.
Yeah.
Exactly.
Doctors and nurses, they've seen it all. They don't mind talking about it, right? It's not a big deal. Promise, promise. Um let's see if there's any more. I think that's all of them. Somebody asked about the treatments and what is the general prognosis at each stage. I feel like we've kind of covered that. And the bottom line is do your screenings because the earlier we get it, the better off we are,
Right.
right?
Yeah. The treatments are very different for different stages.
Yeah. Well, your
Purely,
numbers earlier about 5 year,
yeah, yeah. The
90% in
5 year
stage
survival.
one versus 15% in stage four. That's
Yeah.
huge. That's
Mhm.
huge.
So it's like it behooves you to actually get screening so that early diagnosis can actually lead to
Right.
a cure,
Right.
or
Right.
or bring symptoms to your doctor's attention, because even that can help you identify it,
Yeah.
but the symptoms are so nebulous that you may easily brush it aside.
Right. I think that's a big takeaway from for me today from the beginning of this conversation is that it is a lot of those symptoms are easy to just chalk up to normal life.
Right.
But like
Stress and
if
diet.
it goes weird, don't be afraid. Don't be afraid to call your doctor.
Right.
Call your doctor. Call
Don't
your
be afraid.
doctor.
Don't be afraid.
Yep. 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 Um okay, I think yeah, that's all my questions. That's all the Q&As that have come in. So is there anything you want to end with?
No, I just feel that extremely important for people to take charge of their own health,
Mhm.
and we hope that Clyvera, as a healthcare companion, would be partner with you
Mhm.
in both health and sickness,
Yep.
and guide you into your right direction, what you would need to do to optimize and keep yourself healthy.
Right. All right. Excellent. Well, thank you. This was, as always, really helpful. I learned.
Thank you.
I learned a lot.
Same,
So
same,
thank
same.
you.
You always keep me grounded.
All right.
And
Well,
of course,
until next time, we'll be
all right,
back with another topic shortly.
absolutely. Thank you,
All right.
everyone.
Thank you,
Have a great
Rohit.
day.